Okay, for my patient outcomes rehabilitation plan, I did mine on sciatica. So, a little bit about my PICO. It was in a Division One collegiate soccer player suffering from sciatica secondary to a complete hamstring avulsion. Will they be able to return to play at pre-injury level following a conservative rehabilitation plan? So, a little patient information. My patient was a male Division One soccer player. He was 20 years old, a midfielder, and had 15 years of soccer experience. He had no previous history of injury to his right leg, and he had suffered a complete hamstring avulsion on March 16th, 2020. So, diagnosis. Patient was complaining about pain and paresthesia down the leg, and so he was referred for EMG imaging. This was prior to his diagnosis of a hamstring avulsion on March 5th. So about a week into his conservative rehabilitation of his hamstring avulsion, because he chose a conservative route versus surgery, he was complaining of pain and paresthesia down his right leg. So after his athletic trainer did an extensive evaluation, manual muscle testing, and a more neurological based exam than they did the first time to diagnose the hamstring avulsion, he was referred for EMG imaging. Following this, it was concluded that secondary to his hamstring avulsion, the athlete had developed an injury to his sciatic nerve causing these neurological symptoms, and was diagnosed on March 23rd, 2020. So the timeline for his rehabilitation, his initial evaluation for his hamstring avulsion was on 3/16/2020. His conservative treatment for that instead of surgery started on 3/16/2020. A week after that, his secondary diagnosis of sciatica was done, and then his conservative rehabilitation for that started the same day on the 23rd. The first phase of his rehabilitation plan ended on April 6th, 2020, and then started phase two immediately after, which ended on 4/20/2020. And then he ended phase three on May 4th, 2020, and was cleared for return to play fully on May 5th, 2020, after 6 weeks of rehabilitation. So, during his initial evaluation, he had ecchymosis and edema all on his upper right leg below his buttock, and he had a positive straight leg raise test. He had several range of motion deficits, including hip extension, which was only 20 degrees and painful, and knee flexion, which was only 125 degrees and painful, and ankle plantar flexion, which was painful and 37 degrees. For his manual muscle testing, for hip extension, he scored a 2 out of 5. For knee flexion, he scored a 3 out of 5. And for ankle plantar flexion, he also scored a 3 out of 5. So his diagnosis was complete hamstring avulsion with sciatica secondary to that injury. My initial plan for him after the first visit was, So the short-term and long-term goals for him upon his first visit were to reduce pain and paresthesia for short-term, and for long-term it was to restore pain-free range of motion, strengthen the musculature around his sciatic nerve, so his glutes, his hamstrings, and then to return to play fully. And so during his first visit, he had e-stim on pre-mod for 80 to 150 for 20 minutes. He had passive stretching done, so like hip extension, knee flexion, ankle plantar flexion, and dorsiflexion, and then had ice over his nerve after for 20 minutes for his pain. And then the initial plan for him following his first visit was to progress through 3 phases of rehabilitation, each of them lasting 2 weeks. So his follow-up evaluation on April 6th, so once he had finished his first phase, he had increased his range of motion, so his extension increased to 22 degrees, which was 2 more degrees than he had prior. His knee flexion was at 133 degrees, which was 7 degrees higher than before, and his plantar flexion improved a lot, being 10 degrees higher than before at 47 degrees. And his strength and his musculature improved. His hip extension was a 3 out of 5, and knee flexion and ankle plantar flexion were both a 4 out of 5. So his pain was also decreasing, but not very much, and his range of motion is quickly increasing, and strength is much better when compared to his uninvolved leg. So progression to phase 2 was approved, and his goals for phase 2 were to increase his range of motion even further and increase his strength while maintaining the strength that he has already gained back. And then his long-term goals were to have no pain with any functional movement and begin dynamic exercises, because in this phase he was just doing very easy, like active exercises that were stationary, not a lot of movement, not a lot of agility. So for his phase 2 follow-up evaluation, his range of motion increased almost completely back to normal. His hip extension was at 29 degrees when normal is 30, so it was the same bilaterally. Knee flexion was 137 degrees and normal is 140, and it was the same bilaterally. And ankle plantar flexion, normal range is 50 degrees, and he had 50 degrees of plantar flexion. And manual muscle testing was all 5 out of 5 for extension flexion and plantar flexion, and was equal bilaterally with the uninvolved leg. Isokinetic testing was also increased during this phase, and he can now progress to the third phase and begin sport-specific exercises. So his short-term goal is to return to normal activity with no pain. If any pain was felt during this phase or the next phase, he would regress back to what he was doing before in order to prevent that. And then long-term is to return to play at pre-injury level, since his pain is decreased and he is feeling better and more confident in his abilities. So for his discharge evaluation, he was discharged on May 5th, 2020. He had a score of 0 out of 10 on the visual analog scale for pain. He had a negative straight leg raise test. His manual muscle testing for hip extension, knee flexion, and ankle plantar flexion were equal bilaterally. And his isokinetic testing, his peak torque for his body weight significantly increased from his beginning scores. The goals he completed were he gained full pain-free range of motion, he restored and maintained his strength bilaterally, and he gained confidence in his abilities and was performing at pre-injury level. So he was cleared for all practice and game activity, and the only restrictions he had were to stop any and all activity if pain is reproduced, and to come and tell me so we can address it and regress back until he can perform at the same level with no pain. So, evidence from literature, hamstring avulsions can often lead to injury to the sciatic nerve. This can either be from an accident in surgery or secondary to the injury. This can be due to contusion, stretching, or compression of the nerve, or it can be secondary from entrapment of the nerve by scar tissue. And this can develop either acutely or chronically. Early intervention is important in identifying sciatica and treating it appropriately. More often than not, when diagnosing a hamstring avulsion, there is not enough neurological testing done in the initial evaluation, and the symptoms of sciatica are overlooked because of the severity of a hamstring avulsion, that they just don't really look into it. So it's more common than most people think, but it's still not the most common thing. Sciatica can often resolve itself, but it can be treated either surgically or conservatively. A lot of people try to go the surgical route because they think that they will have faster pain relief than they will with conservative, but there's no literature to support whether conservative efforts or surgical intervention can resolve sciatica faster than it would resolve itself without any intervention besides rest. Too little movement is harmful, but too much movement reproduces symptoms with sciatica. This is why developing an individualized rehab plan is important when treating sciatica. In 1/3 of patients, it will resolve by itself. But back to the surgical and conservative. But when sciatica is caused by something anatomically in the back, it is often better to treat it with surgery to address the problem in the back that is aggravating the sciatic nerve. Whereas in injuries where the sciatic nerve itself is injured, conservative treatment is often a lot better. Um, both treatment routes, their main focus is on pain relief. So modalities and stretching are used for pain relief, and strengthening exercises are good to prevent denervation. Um, modalities and stretching can be used during initial treatment for pain relief to reduce the initial pain and paresthesia, which is the most debilitating symptom of sciatica. And then strengthening exercises are good because, like I said, too little movement is harmful, which would cause denervation in the area. So doing strengthening exercises to prevent that and maintain any strength that there is necessary. And most people, after going through the conservative route, if they can't find relief from their pain or regain their strength back, will then turn to a surgical route to address their sciatica. And then this is my bibliography. And that is it. Thank you.